Hi everyone, good afternoon. It's nice to see all of you again here, virtually, see you, not literally. Anyway, because it's Friday, so we're in a little bit of a flighty mood today. Today we will be talking about, it's an oncological subject, and it has to do with the current COVID-19 situation. Yeah. First of all, I'd like to welcome all of you again to Doctors Go Live, which is a program on Column Asia Facebook, which is on once or twice a week. And we feature our consultants from Columbia Asia hospitals, and we address different subjects. And of course, you are more than welcome to key in your questions so that we can broach the subject and the doctors will get to address it on the spot. So today we have with us, okay, first of all, let me just introduce the topic to you. The COVID-19 pandemic has certainly caused significant changes in life as we know it. Cancer care, for example, is also affected in areas such as screenings, tests, and treatments. Even the daily routine of a cancer patient has had to evolve according to new norms. To give us an insight on cancer care management, not just any cancer care management, but cancer care management in the current COVID-19 situation is Dr. Jayendran Dharmaratnam, consultant clinical oncologist of Columbia Asia Hospital, Bukit Rimau. Okay, so hello, Dr. Jayendran.
Hi everybody.
How are you today?
Very good, lovely. Thank you. Look forward to this, and thank you all for tuning in to and giving me this opportunity to talk to you.
It's our pleasure. It's our pleasure because we've got a very interesting topic on oncology. It's not just a straightforward cancer topic. It's actually about cancer care in this day and age whereby things are very, very different than we've ever known because of the pandemic. So maybe we can start off with you describing what exactly is cancer care management. What does it comprise of?
Well, cancer management is actually a process or a spectrum of care that involves the patient being taken right from the point of diagnosis and until the patient is cured, or until or to the point where the disease can be prevented from progressing further. And the idea is to do this in as safe a manner as possible. So it would encompass other aspects of care, such as rehabilitation, supportive care, and in the situation when the patient's disease progresses beyond treatment, we have to provide a certain level of quality of care, and this is called as palliative care. Okay, so in order to do this, there are many aspects, as I said, because of the many aspects of cancer care involved. It requires a team of doctors and nurses, together to bring about the best outcome. Right from the point of diagnosis, where a pathologist is involved, and then proceeds to lab diagnosis to be able to assess the overall health status of the patient, and then to radiological diagnosis to measure the extent that the disease has spread. And all this information will be put together so that using all this information, we will be able to come out with a treatment protocol. And in many of the developed countries, like even in Malaysia, we use a system called evidence-based medicine. And this is with the intention that treatment is provided in a safe manner, and treatment is transparent and accountable. Obviously, the treatments will vary widely depending on the type of cancer, the extent of the disease, the condition of the patient. And so treatment, with the knowledge that we have today, the evolving knowledge that we have today, it begins to get individualized, or what we nowadays call as precision medicine. The duration of the treatment will also vary according to the situation, and sometimes it can be very prolonged, and the patient is not cured, then then we still try to prolong the disease and manage the patient as best as possible. towards the end when bringing supportive and palliative care. So, in short, you can say cancer care is an evolving art and an evolving science that leads us to find solutions for a difficult disease such as cancer. Thank you.
Yeah, that sounds very, very extensive, Doctor.
It,
Very comprehensive.
it involves a lot of things.
Yes, yeah, it involves a lot of a plethora of facets there. Okay, before we go into the present, perhaps you can generally describe cancer care management in Malaysia prior to the COVID-19 pandemic.
Well, that's a long story trying to.
It's okay, you can, in a nutshell.
But in a nutshell, we can say that we have, besides what I have already stated, we try to improve. In Malaysia, we try to implement some of the most important principles of a model national cancer service. And what some of these would be, first of all, accessibility. Accessibility means not just to cancer treatment, but to this comprehensive cancer care that we are talking about. It must be made accessible not only to the people in the cities, but also to the rural population. Okay, so that is important. Number two is comprehensiveness. Like I said, it is not just about doing a surgery and that's the end of the story, but all the other aspects of cancer care must be involved. Sometimes it requires a multidisciplinary management involving so many other people. Number three is, I would say, is cost effectiveness. It is important to make, at least in the government hospitals, it is important to make treatment cost effective. There are a lot of people who cannot afford many of the expensive treatments, and that is why the government is very cautious about allowing many of these very expensive treatments to come into the country. And you go through the process of registration of drugs and things like that. Fourthly, I would say is patient-centered care. Patient-centered care is one that takes into consideration the patient preferences, needs, and values before we can implement a treatment policy. And especially in a country like ours, with all the diversity, race, religion, and so on, patient-centered care is very important. Of course, along with these concepts that I mentioned, we also try to keep up with the latest cancer management trends. And especially because there is the new sciences and technologies involved in treatments such as radiotherapy and medical oncology. And also we adopt what is known as evidence-based medicine, which I stated before. And this evidence-based medicine comes about as a result of well-conducted clinical trials and research, mainly in the academic institutions. But nowadays, more and more private hospitals are also getting involved in such research activities. Of course, Malaysia, we also contribute to peer-reviewed journals and publications, and again, this with the intention of making treatment as objective and transparent as possible. I suppose it is because of this policies that we have in as far as cancer care is concerned, that we see today a lot of people, foreigners from overseas, coming to Malaysia as health tourists. However, I must also mention that there are some inadequacies in our policies also, because the uneven distribution of cancer care resources throughout the country, especially like me, where I spend a lot of my time in Sabah. I see many of the rural people who do not get access to good cancer care.
Okay, so this is the situation, the current situation you just described.
Yes.
Okay, how has the pandemic disrupted cancer care, which we have just been told just now? How has COVID-19 affected cancer care in Malaysia so far?
Well, first of all, you must understand that no healthcare system in the world, including ours, has been fully prepared for such an unparalleled health crisis. The COVID pandemic has put a lot of strain on the healthcare services, and affected directly or indirectly the cause and treatment of many illnesses. Quite a few procedures had to be deprioritized in order to make way for the COVID pandemic management. Some of these disruptions, for example, to start with, screening. Not many people are coming forward for screening for their breast, for example, mammogram, pap smears, and all that, which means that diagnosis of when the cancers arise, the diagnosis will delay. Many of the diagnostic services also had to be disrupted. Some of the screening and diagnostic procedures like scopes, bronchoscope, the endoscopes, to look into the stomach and esophagus, some of these procedures had to be shelved off. Why? Because there is a higher risk involved when doing these procedures, because many of these procedures they can lead to aerosol, and aerosol transmission of the COVID virus. So either these procedures had to delay or deferred.
Doctor, sorry, I'm sorry to interrupt, but would you say that not many people are willing to go to the hospital to do health screenings and of course to check on whether they have cancer or not? Because number one, there's this pandemic, so people are naturally nervous about going to any place whereby they feel there is any risk of infection. And then on the medical side, would you say also because cancer patients, generally, they all have a much lower, efficient immunity system.
Much more.
I don't know. That's just. I'm sorry. The immunity of cancer patients are
less reduced.
Cancer patients that it's a lot lower.
Yes, cancer patients generally they have found that they have reduced immunity either because of the cancer or because of the treatment that they are undergoing. So their immunity is reduced. As far as possible, people don't want to go to hospitals because hospitals are seen as a source of infection. Right? Yeah. Number two is, of course, when in a situation with this pandemic, obviously screening becomes deprioritized. It doesn't appear to be so important. People might turn around and say, never mind, I will keep my mammogram or my pap smear later, maybe I can do later. So, so it becomes deprioritized,
Yeah.
And other investigative procedures like biopsy, because biopsy involves a surgical procedure, which carries a bigger risk. Therefore, not only the patients don't want it, doctors too will be reluctant to do procedures because of the risk of infection. Other investigations like radiological investigations also gets deferred and delayed. And of course, you must take into consideration many people in the country are still living in rural areas. Many of the cancer treatment facilities are all mostly in the cities, okay, like KL, Malacca, Penang, and that kind of thing. People in East Malaysia, East Malaysia is such a big area, and there are only 2 centers in Kuching and Kota Kinabalu. How are these people going to get to these centers when they are living so far away? So the logistic problems also come.
Okay. Cancer centers.
Yes, cancer centers.
Specifically for cancer. Okay.
Yeah, and besides that, the other aspect that you want to look into is that the treatment pathways in cancer are well developed as a result of years and years of clinical trials and research. But now the treatment pathways gets disrupted. Treatments like radiotherapy will become abbreviated, shortened. Chemotherapy will not be given in the safe and efficacious manner that used to be given, because everything is being abbreviated so that the patients spend less time in the hospitals. Now, many of these changes in the treatment pathways may not follow proper evidence-based medicine. So we are not sure what the outcomes may be in terms of safety and efficacy.
Yeah. Doctor, excuse me, sorry. You mentioned just now that some of the treatments may be abbreviated, that some of the treatments are shortened, but why is that? Is that because cancer obviously is a time-sensitive disease, and the treatments are also time-sensitive, but why would the treatments be shortened if it is not required?
Conventionally, treatments are, example, radiotherapy. Okay, conventionally, radiotherapy to the breast or any particular organ it's done in number of fractions. The more the number of fractions, there's better safety and better efficacy. So treatments may be stretched over a period of about 4 to 5 to 6 to 7 weeks. But in the situation where we are trying to reduce the number of visitations of the patient to the hospital, the treatment may be cut short to 2 or 3 weeks, in which case the fraction size of each treatment becomes bigger. These can potentially cause problems. Chemotherapy, for example, there are different schedules of chemotherapy. Some of the chemotherapy schedules may be weekly, some may be 2 weekly, some 3 weekly, but because of the situation, the schedules may be stretched out. And sometimes the chemotherapy may not be given as intravenous. We may substitute with oral chemotherapy drugs and things like that. So these are some of the changes that may take place as a result of trying to reduce the risk. Another situation is, like I mentioned, many of these treatments require multidisciplinary input with surgeons, oncologists, and many other people working together in order to bring out the best outcome. In a situation like this, where this pandemic, we want to reduce the visitations of the patient to the various clinics in the hospital. So a multidisciplinary concept becomes very difficult to implement in this kind of setting.
Doctor, out of all the effects that you mentioned just now, about how cancer care is now challenged due to the pandemic, which one is the number one challenge that oncologists face?
Well, based on my of course, this is a matter of opinion. Based on my own experience of being an oncologist for 25 years, which I spent quite a bit of time in the government setting, and I've been in various places, in Kota Baru, in Sabah, and so on. I would say the most important thing is accessibility to comprehensive cancer management. Because a lot of people in the rural area, I've seen situations where people have, in order to treat their breast cancer, have to walk through many miles, through 2-3 different towns from the rural area to get to proper cancer treatment facility. And that journey itself takes so many days and really compromises on the health of the patient. So I think that what we need in this country is to set up more cancer treatment facilities widely throughout the country.
Okay, got it. Yeah. So that's the number one challenge, whether, regardless of whether we are in this pandemic or not, it's always about accessibility, correct?
Yeah. Yes.
Okay, all right. Pertaining COVID-19 SOPs and screenings, how are procedures any different for cancer patients?
From the limited data that we have got from China and later from countries like Italy and US, we realize that there is indeed a higher incidence of COVID-19 in patients with cancer. But that is not to say that all cancer patients should be put into the same basket and they should be stringently screened for COVID-19. We have to look at the benefit risks of whatever procedures that are undertaken. Of course, the usual SOPs, the standard operating procedures, social distancing, wearing masks, washing hands, and things like that, will always be there. But on top of that, in patients with cancer, we will go that bit more towards checking on the we probably have a thorough discussion with the patients before we invite them to the hospital. Much of this discussion will be done through either telemedicine or teleconsultation or by phone. We will ask them questions pertaining to their exposure, and they will be also given proper health education. They will be informed of the safety protocols that they will have to abide by if they come to the hospital, and they will also be given advice on with regards to their family members who can accompany them. So basically, there is no hard and fixed procedures that they need to go through besides their normal standard SOPs. In some centers where the patients undergo surgery, these patients, because they have cancers are many different types, and the procedures that may be done also may be of different types. So they may be put into different risk categories. They can be put into a high risk category, intermediate risk category, or the lower risk category. And based on the risk categories that they are put into, they may have certain more stringent procedures that they have to follow. Some of them may require to be quarantined for up to 2 weeks. They have to be self-isolated for 2 weeks, including their family members, before they are considered safe enough to be brought into the hospital. Some of them, even before the procedures, they may have to do COVID swab tests up to about 48 hours or 90 or 96. In fact, they have to get it done twice, 48 hours and 96 hours before the procedure. So there are certain patients who may have to have much more stricter procedures done, screening procedures done. Some of these patients are especially those patients who have comorbid problems, high blood pressure, chronic kidney disease, diabetes, and these are the patients where we need to be more vigilant. So it varies from hospital to hospital. In our own hospital, we make it a policy that all patients who are admitted for cancer treatment will undergo the RT-PCR antigen COVID testing. But those who are maybe seen as outpatients will probably do the testing according to the
need. Okay. We addressed the SOP for cancer patients, but what about if we're talking about visitors, talking about family members, caregivers, apart from the standard SOPs like wearing masks, social distancing, are there any other regulations or advice that you can give to not increase the risk that the cancer patient already has by virtue of having cancer? I'll give you an example because my auntie was just diagnosed with cancer, and not even her children are allowed to come near her. So, some of them may find it very puzzling because this has never happened before. So, obviously, it's the COVID-19 effect. Perhaps there is some advice that you have?
Yes. I would say, first of all, patients should be advised to avoid being exposed. Because if they get exposed to COVID virus, the situation treatment is going to be more difficult. So this is the most important thing that should be emphasized. Try and reduce the risk of exposure. Okay. Then it is necessary, if possible, for the patient to talk to their cancer care team. Again, either through teleconsulting or by phone, so that they are kept abreast of the safety protocols that they will have to adhere to and what they will undergo when they come for their treatment. Certain procedures like I mentioned, those where there is aerosol formation, like during scopes and things like that, they will, as far as possible, we will try and delay it or defer this uh, thing, and maybe if necessary, we will find alternate ways of trying to diagnose their problem. Uh, yeah. So, and treatments may, even when it comes to treatments, surgical treatments, like I mentioned, will be deferred or delayed, and they may be put into certain risk categories, depend on the kind of cancers and kind of risk that they carry. Um, the other thing is, of course, if we manage these patients, we will try to do this in a multidisciplinary setting, whereby not only the oncologist and the cancer care team, but we will also involve physicians, uh, ICU people, things like that, so that whenever there is a situation that warrants it, we get everybody involved in the whole management process. Um, Treatments must be looked at from a benefit risk perspective. Those patients who have the disease where the treatment brings more benefit can go through the treatment. But when the risk is higher, then again treatments will be delayed or deferred. Let me give an example. An elderly man with prostate cancer. We know prostate cancer is a disease which you can live with for years. It's an indolent disease, slow growing disease. So, in this kind of situation, we can tell the patient, look, you defer your treatment till maybe when the situation is better to come for curative treatment. Prostate cancer is a cancer that can even be managed through using of hormones. Another situation, a young woman with breast cancer, who, and in a young woman with breast cancer, we know it is with early stage disease, we know it is a potentially curable situation. So the risk by comparison is less compared to the benefit. And so she, as long as the safety protocols are followed, she would be encouraged to go for immediate surgery. Another situation, an elderly woman with breast cancer, which on biopsy shows to be hormone responsive. In that case, we will probably advise her to defer treatment using anti-hormone treatment to control the cancer till a safer situation arises when she can undergo surgery. So, in this way, treatments will be individualized in order to reduce the risk. Okay. Yeah. So, yeah, and there are other ways of reducing risk. For example, cancer centers will need to implement safety protocols. Patients who are at high risk may be put into private rooms. Areas in the hospital, for example, the pharmacy, the daycare unit, and all the things, will have to follow strict SOPs like regular cleansing, making sure that the patient's sitting area is well spaced out, even giving bigger gaps between patient appointments and such. Of course, in the near future, maybe once a vaccine is available, the guidelines will change, and patients who have especially high risk cancers like blood cancers, lymphomas, and all that, they are, because their immunity is lower, they are at a higher risk. So these patients may need to do things like antibody testing and things like that, so that they can continue with their treatment and follow up and so on. So these are all the procedures. Of course, it all varies from one center to another.
Yeah, when we're talking about the varying risk of cancers in patients, the varying risk of contracting COVID-19, does that depend on the kind of cancer that a patient has, or does that depend on the advancement of the cancer, the extent, the stages?
It
What I
depends.
mean is that with breast cancer, does that come with more risk compared to someone with lymphoma, for example?
Lymphomas, blood cancers carry higher risk because as a result of the disease, their immunity is reduced. Breast cancer is not one because breast cancer is a wide spectrum of disease. It can be very advanced, it can be very early. So again, it depends on the stage of the cancer. Okay, but in general, you can say that cancers like myelomas and lymphomas, where the treatment also involves stem cell, marrow transplantation, immunotherapy, and things like that. These treatments themselves also will reduce the immunity. So they carry a higher risk. Yes, you are right. Type of cancer makes a difference. Stage of the cancer also makes a difference.
Okay. You mentioned just now the types of cancer that come with very high risk would be lymphoma, blood cancer.
Yes, that's right.
Another one or two, just
Yes,
for.
myelomas, lymphomas, leukemia.
Okay. Blood cancers lah, generally. All right. In your opinion, doctor, between the two diseases, which has neither cure nor vaccines, and both also have a heavy dependence on machines and medical personnel, which one is the healthcare priority in this crisis and why? Yeah, is it given that COVID-19 is the more pressing matter, or that does
Well,
not?
of course, we doctors, we still continue to learn about the potential risk of
Yeah.
COVID-19. But COVID-19 is an infectious disease. It's caused by a virus that has a short and limited lifespan. During the time that the virus is inside the host, it will try to progress, and at some stage, the virus will die off because the host dies off, or because the host immunity kills the virus. The virus, of course, will try to start a new life cycle in another host, and so it will spread. But while it's in one host, the lifespan is only for a few weeks, unless the host is got comorbid problems like high blood pressure and diabetes and chronic kidney disease, in which case the virus can continue to survive a little longer. Whereas cancer, on the other hand, is a non-communicable disease. It takes a longer course and is the result of abnormalities within the patient's genetic, cellular, and immune systems. In general, cancer takes a longer process, longer time, week, months, years. In general, managing COVID-19 and its complications, of course, is a much more urgent. It is a battle. It's a short battle. Whereas cancer is more like a war, long-term war. So, of course, one would say it's more important to prioritize COVID-19 management first. But if you leave the cancer without treating, the cancer will progress. So there are times when you may have to treat both the COVID-19 and the cancer together. It depends, of course, on how quickly cancer is progressing. Yeah.
What's the most aggressive cancer, doctor?
Right. So there are situations where both of them can be treated concomitantly together.
Okay. No, I was just curious. What's the most out of all the cancers? Which type of cancer is the most aggressive that tends to escalate very fast if treatment is delayed or treatment is postponed?
Well, in fact,
would it be blood cancer?
There are many different types of cancers, but those cancers which tend to mutate and proliferate faster, obviously, they are more dangerous and need to be treated faster. But even a particular cancer, let's say breast cancer, there is a whole spectrum of diseases within breast cancer. You can have the breast cancer which is indolent, slowly progressive, And you can have also a breast cancer which is rapidly progressing. So within the particular type of cancer itself, there are different subtypes. But if you talk in terms of site, I would say that cancers which are more rapidly progressive will be like lung cancer, and also because lung cancer has a lot of complications, respiratory complications. Breast cancer can also progress very fast. Lymphomas, leukemias, these are also very rapidly progressive cancers.
You go as a patient, if you go to a cancer center for treatment, would the priority to treat the patient depends on the nature of each type of cancer, or this is purely case by case?
Well, we have to look, treating cancer is a complicated affair. You have to look into every aspect of it. You have to look at the type of cancer. You have to look at how rapidly it has progressed. You have to look at the patient's general condition. Same type of cancer may be treated differently in an 80-year-old and in a 30-year-old. So there are many factors that come into play in deciding the proper cancer treatment protocol.
I see. Okay. If we're talking about treatments that come with very high risk of infections, what would be a safer alternative?
Well, it is difficult to look at any safe alternatives for cancer treatment. After all, cancer treatment is something that has progressed over the years as a result of research and the clinical trials. So, if there was a safe alternative for treatment of cancer, I'm sure everybody will be going for that. Unfortunately, it's difficult to state that. However, you can say that the risk from COVID-19 will come from two aspects. One is that any procedure that increases the risk of transmission. For example, like I mentioned, if you do scopes, there is aerosol formation. If you do surgery, because it's an open wound, things like that, these kind of procedures will carry higher risk. That is one perspective. The other is when patients who have got advanced cancer, who are undergoing treatments for their cancer, they end up having lower immunity, and therefore they carry a higher risk of COVID-19. For example, patients who have been on chemotherapy for long extended periods of time, maybe up to 3 months, patients who are having extensive radiotherapy, for this kind of patients who are having blood transfusion or bone marrow and stem cell transplant, patients who are on immunosuppressive drugs like targeted therapy, immunotherapy. Now, how do you find safe alternatives for this? That will be difficult. Of course, patients who are on chemo, you can put them on something gentler, like oral chemotherapy and so on. But then, of course, you may be compromising on efficacy. For patients who are undergoing extensive radiotherapy, you might consider them minimal low dose radiotherapy. Again, you may be compromising on efficacy. So it is very difficult to find safer alternatives. In terms of diagnosis, of course, maybe you could do, instead of doing biopsy through surgical means, we could come to empirical diagnosis from radiological investigations. The other thing, of course, in the future, we should be depending more on things, new technologies, artificial intelligence, to be able to bring about safer diagnosis without invasive procedures. One such example is like, for example, liquid biopsy. It's a very new technology where diagnosis of particular type of cancer can be made just by taking the blood and looking at the circulating cancer cells in the blood. So yes, probably in the future, we have to look at newer technologies and artificial intelligence.
Are those to do with cancer markers, or that's a completely different thing altogether?
Cancer markers is one way of coming to an empirical diagnosis. Yeah.
I see. Okay. From your experience, have you seen a drop in the number of patients at your oncology clinic so far? And what do you perceive as the reason for that?
Well, in my own practice, yes, there was a considerable drop. It is
Mm.
improving now because this, there are no more lockdown now, so patients are able to, the logistical problems are not so much there. Part of the problem, of course, is because of the fear of transmission of virus. You know, people perceive hospitals as probably not the safest place in the world. And the other thing is, of course, the logistics of care. Many people, especially in a lockdown, it is very difficult when you can't even move around. What else you want to come to a hospital which is maybe 100 miles away? Uh, and um, and uh, and you must understand that comprehensive cancer treatment facilities probably exist only in about 8 city regions in the whole country, from
Yeah.
Penang to Malacca to Johor Bahru, Kuching, Kota Kinabalu. So there's a lack of facilities in other parts of the country. The other thing, of course, I would like to mention is the fact that certain places like Penang and Malacca, they have seen much more drastic drop because most of the hospitals there, especially the private hospitals, depend a lot on health tourism. Now, well, foreigners can't come into the country for their cancer treatment. So as a result, many of the hospitals, the doctors have seen a drop, and because of that drop, the hospitals also lose revenue, and indirectly it means that the government also losing revenue because patients are not able to. And it is these unfortunate patients that I feel sad for, because many of them, they leave, from Indonesia and all that, because they don't have very good cancer treatment facilities. They come to our country for cancer treatment, and now because of all the lockdown, they can't come.
Understand. How will cancer treatment be influenced as a result of COVID-19 crisis? I mean, it's a big picture question. Maybe you've got a summary to answer this question.
Yeah, again, there is no one size fits all kind of policy. Probably, I would think that in the first place, there will have to be new guidelines for treatment to be developed, and doctors should be well versed in these new guidelines. Of course, new guidelines are not something that can be set out overnight.
Of course, yeah.
And it needs well-respected cancer treatment organizations like the American Society of Clinical Oncology, European Society of Clinical Oncology, pool in all their data, and so come out with guidelines. Patients with weakened immune system will especially need this kind of new guidelines. Okay, because for them treatment pathways will have to be different. Diagnostic procedures, like you mentioned, may have to look at newer technologies like like liquid biopsy and so on. I'm just thinking that gone maybe the days when those days doctors used to have a stethoscope around listening to the heart and lungs of the patients. Nowadays, I don't think I see that many doctors carrying stethoscope around. Nobody wants to use a stethoscope and a patient who is breathing away into their face. So things will change. Age-old traditions of clinical diagnosis may give way to the newer technologies. Hospitals and facilities in future have to be designed to take into account the risks of such pandemic infection. You must understand, this pandemic may come and go, but in future, I'm sure there will be other pandemics will be probably coming along. And so hospitals have to be geared up for this kind of situation. So it requires a lot of organizational structure, and people working together and things like that. Treatments like surgeries may be deferred or delayed. Treatment regimens like chemotherapy regimens may be relooked protocols of chemotherapy regimens, maybe radiotherapy treatments, like I said, will be may not be in the traditional way of long course of treatments. Novel treatments like immunotherapy and targeted therapies will have to be carefully considered because of the potential of complications like respiratory complications and cardiovascular complications. Some of these complications of immunotherapy and targeted therapy, they mimic a COVID infection. Sometimes difficult to make diagnosis. I think one of the other important things is because of the fact that cancer and COVID-19 infection both are related to immunity. I think there has to be a bigger emphasis on managing immunity, healing immunity through integrated concepts of care. There's nothing wrong with traditional treatments. I give my patients sometimes moringa because it's supposed to be a superfood, it's supposed to improve immunity and things like that. And many patients see benefit of that. So I think that our research methodologies and our treatment policies in future should look into how one can improve one's immunity. The other thing is, I think, in the future, patients who come to hospitals, especially patients with cancer and other chronic conditions and all that, will probably end up having routine antigen antibody testing for COVID and other viruses. We also should look at addressing accessibility of cancer treatment facilities in the country. Maybe more cancer centers will be required, especially with the increasing incidence of cancer. But of course, now that may be a problem because of the present lag in the economy and things like that, So one more thing, lastly, is I think in future consultation will be taking place more by teleconsultation and telemedicine and things like that. So there will be less of exposure, person-to-person exposure.
Yes, it's quite ironic that you actually mentioned teleconsultation because that's what Colombia Asia is just about to launch very soon. That's going to be available soon. So hopefully there won't be,
that's what
a step forward lah. Yeah. Okay. Okay. Last of all, before I end the program with the last question, I would like to just call out on our viewers. If you have any questions regarding the topic, which is cancer in this day and age of during this pandemic age, please do type your questions in the comment box, and then we will read out your questions, and Dr. Jaya will be able to address them immediately. If not, it's okay. You can just leave those questions anyway, and we will address them as soon as we can. Okay, Doctor, what is the number one lesson that that you feel we all should be learning from this pandemic experience, from a cancer care point of view?
Well, to me, because I play sports, and I think one of the things important, I think, is that if you have a good immunity, if you keep yourself healthy, doing the right things in life, I think you can manage all kinds of conditions. So, and we have seen it in all the months of COVID infection, what has followed. People with lower immunity are the ones who are at risk, not only for COVID infection, but to also diseases like cancer, high blood pressure, diabetes. So, eat well, avoid all abuses like alcohol and smoking and all that. Exercise, sleep well. I think these are some of the measures, and it's almost free. And these are some of the measures that you can do to improve your immunity. And if you got good immunity, you can keep all conditions under control.
Great, good advice. Thank you so much, Doctor, for your time today. Okay, we've got to wrap up our session. And we've just been talking to Dr. Jayendran Dharmaratnam, who is the consultant clinical oncologist from Colombia Asia Hospital, Bukit Rimau. So that's all the time that we have today on Doctors Go Live. Thank you, Dr. Jaya.
Thank you so much. Thank you, everybody. Thank you.
Thank you.